our next case, that is cleft lip and cleft palate. And I will invite our just a minute. And the case presenter is Dr. Abhishek Kumar, who is director and radiologist in the M3 Diagnostics, Greater Noida West. And he was formerly with the consultant Fortis Hospital, Delhi. He was chief radiologist in House of Diagnostics, HOD Suraksha Diagnostic, Delhi, and he has a special interest in fetal medicine. For the fetal medicine input, the expert input, we have our stalwart Dr. Mohit Visa, who is National Vice President of Musculoskeletal Ultrasound Society and National Vice President of Society of Fetal Medicine. He has postgraduate diploma in musculoskeletal ultrasound from University of Murcia, Spain. He is national treasurer of IFUMB. He is organizing co-chairperson of the International Musculoskeletal Ultrasound Conference in 2015, 17, and 2019. He is course coordinator of UCAM 2018 and 2020, and he has his Center of Advanced Ultrasound Guided Intervention in Genetic Clinic in Sakanka, Mumbai, by the name of Abhipraya. We have Dr. Neera ma'am for the clinical input, who is MD MRCOG, FRCOG London. She is FICOG, FIM, FICMCH. She is diploma in advanced endoscopic surgery from France. She is senior consultant gynae and obs in Ghaziabad, and she is a specialist in endoscopy surgery and high risk pregnancy. Now I'm inviting Dr. Abhishek for the case presentation. Please share your screen, Dr. Abhishek.
Am I audible?
Yes, sir. Yes, sir.
Okay, thanks, Dr. Gopal.
Mute yourself. Other people except Dr. Abhishek.
Thanks, Dr. Gopal. Thanks for allowing us to share this presentation. Okay, I'm starting with my case. This is 26-year-old female, married since 1 year.
Sorry to interrupt. Your
screen is not shared, sir.
Yeah.
Okay.
Yeah, perfect.
Yeah, starting with the case, it's 26-year-old, married since 1 year. Her LMP was 28th of May 2020. There was no significant past history, and there was no significant history of any diabetes, hypertension in the family, and there was no congenital anomaly or chromosomal disorder in the family. Her dating scan was normal. Her NTNB scan was unremarkable. She came for the anomaly scan, and while doing anomaly scan, rest of the things were normal. We found just a small lucency in the upper lip, which is extending up to the nostril. Then this forced me to do the SAG scan, and the SAG scan I've seen just a defect which is there in the parasag region of the palate, which was confirmed on the coronal section. This defect was there. So this was diagnosed as a cleft lip, unilateral cleft lip with cleft palate, and was referred. Simultaneously, we did a 3D scan, and while doing 3D scan, I saw a small lucency which is there in the upper lip, and it was extending up to the nostril. So this was diagnosed as a unilateral cleft lip with cleft palate, and it was referred to the higher center for the prognosis. Another case was seen with a similar lucency which was there in the upper lip, and rest of the findings were normal. Again, the 3D scan was done, and we can see a small lucency which was there, and this was diagnosed as an isolated cleft lip, and again referred for the higher center for the prognosis. So cleft lip was just prevalence is 1:700. More common, 50% both the lips and palates are affected, 25% only lip, and 25% only the palate. Unilateral in 75% of cases and supposedly more common on the left side. So on ultrasound, we see a small defect most of the time, and which extend up to the alveolar ridge, reaching up to the nasal cavity and even the floor of the orbit. So this is the view which normally we see in the, this is the upper lip, lower lip, and the nostril. We can see a unilateral defect, and sometimes we can see a bilateral defect, which is there. We have to do, sometimes color Doppler helps, and we can see a color flow from the oral cavity, which is extending up to the nostril, and we can sometimes diagnose a case of cleft palate. In early anomaly scans, or we can see 11 to 13 week scan, the retronasal triangle helps us in diagnosis, which we can see over here. This is the defect, which we can see the retronasal triangle, and it's some small protuberance of the upper lip, which we can say as a bilateral cleft palate. Thanks.
Hi, good evening all. So I'm going to take you through an approach to the fetal orofacial defects. And the cleft lip palate and an isolated cleft palate are two entirely distinct entities that need to be clearly understood. They can occur as an isolated defect, or more likely they may be a component of chromosomal or non-chromosomal syndromic disorders. And hence, you have to have the right methodology to approach a case with clefting. Fortunately, technological advances and better understanding of embryology and anatomy has made the diagnosis and classification of clefting of lip and palate quite easy. All you need to know is follow protocols, take the right scan planes, and you would be fairly diagnosing them with much more certainty. So as a sonologist, what are you supposed to look at when you get a case with clefting? First of all, you see whether the defect is to one side, or is it only on unilateral, is it bilateral, or it is a median defect and the sides are spared. Look at the type of defect and the extent of the defect. Sometimes the defect would be restricted only to the soft tissues, and sometimes it can extend all the way up to the soft palate. Look at the width of the defect from an anterior approach. I'm going to show you how. Look at the integrity of the maxilla and the alveolar ridge, which is invariably disrupted when you have a clefting anteriorly. Symmetry of nasal orifices. Now this gives you a first-hand indicator that there has to be underlying clefting of the palate. When you see that one of the nasal orifices is flared or broadened, then it is likely that the clefting of the lip has extended to a palate, and therefore there's a communication between the nasal and the oral cavity, and that leads to that flaring of the nasal orifice on one side. So that gives you a fairly good indicator that there could be an associated clefting as well. And sometimes, when you have bilateral clefting of the palate as well as the lip, you have this typical sign called premaxillary protrusion that is evident in the mid-sagittal view, and that basically results from anterior migration of the hard palate and teeth secondary to that clefting. So basic anatomy, I would just like to revise. We have the primary and the secondary palate. The primary palate forms the four central incisors and extends up to the foramen incisivum. So this is the only portion which forms the primary palate. The rest is what is called the secondary palate. So the secondary palate consists of the hard palate, which extends up to the nasal cavity. And when you start seeing the nasopharynx, that palate becomes a soft palate, which eventually ends up in uvula. So you have the primary and you have the secondaries. The secondary consists of the hard, the soft, and ending up in the uvula. So basically, Nyberg classification is what we follow, where the type 1 is extending only to the lip, the palate is spared. When you have a type 2, which is unilateral, but involving the palate as well to a variable extent, it can actually go all the way up to the soft palate, and it even divide the uvula. Type 3 is when you have bilateral clefting of the lip and the palate, and you have a soft tissue and the midline sagittal section, the premaxillary protrusion. And the type 4 is when you have a proper median clefting of the lip and palate. This is usually seen in holoprosen cephalies. And type 5 is generally associated with amniotic bands. So you could have various type of actually no gross anomalies in amniotic bands, but it will restrict to type 4 because this is what we will actually see and evaluate. Why is this important? Because most of the patients who have clefting extending all the way up to soft palate have a lifelong nasal twang, may have difficulty in swallowing, they will have regurgitations, and that's one of the reasons why you would have polyamnios even in the prenatal scans. So one of the causes of polyamnios is clefting extending up to the palate, and that's for when you have a polyamnios, we usually try and check out for the clefting involving the palate. Now, a major difference in understanding that I would like to draw in here is when you have a clefting that begins from the lip and involves the palate, it always starts at the lip and then proceeds posterior to a variable extent involving the alveolus, hard palate, and soft palate right up to the uvula. So the defect extends from the anterior to the posterior aspect, whereas when I talk of an isolated cleft palate, which is an entirely different entity, it always starts at the uvula. So the uvula bifida is the mildest form of isolated cleft palate. Mind you, the anterior cleft, the lips would be absolutely normal. But if you see a bifid uvula, that is the mildest form of isolated cleft palate, and this defect proceeds along the midline in an anterior direction. It can involve the soft or it can extend all the way up to the hard palate. So knowing this entity is extremely crucial to differentiate between isolated cleft lip and palate from an isolated cleft palate. So at birth, the incidence of unilateral cleft lip and palate is the highest, coming to 40%, followed by unilateral cleft lip, bilateral cleft palate, and bilateral cleft lip is absolutely minimal. We are of course not considering major facial clefts in these scenarios, but generally you have unilateral cleft lip and palate as a commonest anomaly when it comes to orofacial cleft. So in ultrasound, how do you diagnose the orofacial clefts? We take stereotype views. For example, in the sagittal view, we look at the palatine line. That's the hard palate there. You see the extent of the palatine line. See the integrity of the palatine line. If you have defects in the palatine line, you're suspecting clefting of the palate. Similarly, you got to understand that the vomer, which forms the base of the nose, fuses with the secondary palate. So you will see a parallel line in all the patients with second trimester anomaly scan. We are not discussing first trimester here, we're discussing second trimester, and you'll always see the vomer as a parallel line to the main palatine line. So the absence of seeing these two parallel lines is a sign of an clefting of the palate. When the palatine line is absent, means the palate is absent, you will only see the vomer bone. So it's important to see both the parallel lines in all sagittal views. When you want to diagnose clefting of the lip, the best section is a coronal view. We know all to take this section. It's a coronal oblique plane, which where you take a plane which is tangential to the nose, lips, and the chin. Then intact nasal tip with two symmetrical nares. This is important. The nares have to be symmetrical, and intactness of the upper lip actually rules out a cleft lip. When you take the retronasal triangle view or the premaxillary triangle, which is a triangle, the sides of which are formed by the frontal process of the maxilla, the base is formed by the palatine process of the maxilla, and the top is formed by the two nasal bones. We, when it concerns the clefting, are more focused on getting the palatine process of maxilla intact. So therefore, when you take a premax triangle, try and be as perpendicular to the palatine process of maxilla to avoid any false defects or apparent artifactual defects in the palatine process. So when you're perpendicular, the palatine process has to be intact. That rules out a defect in the hard pulp palate. The face is anterior. Try and get the axial view of the maxilla from an anterior approach. When you have an axial view there, if you have a clefting, you will see a defect extending from the soft tissues, that is a cleft lip, into the alveolar ridge and into the hard palate. It is best seen in this axial view because it will tell you the length of the defect and the width of the defect. But it has to be an anterior view. If you try and get it from the dorsal or the posterior approach, you may not be that accurate. Even lateral views do not tell the extent of the defects as clearly as an axial view, which an anterior axial view. So this is an extremely important section to take, and here you can see that the defect in the soft tissues, which is extending onto one side, and the alveolar ridge is broken, and you can see the defect extending all the way up to the soft palate. So this is an extremely crucial view that you need to incorporate in your day-to-day practice. Now, because cleft palate, an isolated cleft palate, always starts at the uvula, the presence of an unremarkable uvula implies the presence of an intact palate, an extremely crucial point here. If the uvula is abnormal or cannot be detected at all, this indicates a defect in the palate. So if you want to exclude an isolated clefting of palate, try and include uvula in your day-to-day scanning protocols. It's a simple scan. You just have to do an axial BPD section going down into the neck, and you will see that two equal to sign of the uvula. That's the fluid. That's the fluid on the other side, and you will have the two equal to signs of the uvula. That equal to sign indicates that the uvula is present, and if the uvula is present, you are virtually excluding a clefting of an isolated cleft palate. At the same time, if you have a cleft palate which is starting from the lip and extending right up to the uvula, you may not find an uvula there. So presence of an uvula actually excludes a clefting of an isolated cleft palate. At the same time, it excludes a large cleft lip palate extending the soft palate. So presence of an uvula can be incorporated in the protocols of an anomaly scan, will certainly exclude an isolated clefting of the palate, which is otherwise difficult to see going by the surface anatomy alone. This can also be seen, the uvula, the soft palate can also be seen in the sag view, uh, provided you just angulate the probe towards the palate and the fetus opens its mouth. You will see the hard palate and the soft palate and the uvula there. That's the tongue there, but you see the intactness of the palate when you actually see that in the mid-sag section. Though do remember that mid-sag sections do not pick up side isolated clefting of palates which are on the sides. So therefore, mid-sag is restricted to patients who have bilateral clefting where you have a premax occlusion. That's the case where you have an unilateral clefting of the lip, very obviously seen, and you see the retromax triangle, and it corroborates with the clefting of the lip going on the same side, extending into the hard palate. That's the anterior view of the maxilla. The soft tissue abnormality of the skin extends into the breaking the alveolar ridge, extends all the way up to the soft palate. This is a case of bilateral clefting, and therefore you have this classical premax protrusion there, bony surface, soft tissue there, and 3D is best used to convey the proper perspective to the to be parents or even to the referring doctor. Once sort of, it gives you the right perspective to make the further decision for the patient. So that's the classical bilateral clefting of the lip. And the premax triangle, the palatine plate of the maxilla is absent. You have the classical premax protrusion, and 3D allows you to see the defect in a much better way. When you have median clefting, that is a very proper midline cleft extending up to palate, this is usually seen in holoprosencephaly. Now, this is going to be covered by Krishna, so I'm just going to discuss a brief about the association of chromosomal abnormalities with clefting. Do you remember that median clefts are associated with holoprosencephaly? Bilateral cleft lip and palate have a very high incidence of chromosomal abnormality. Unilateral clefting has half of the bilateral effect, but do remember that association with 13, 18, and rare chromosomal abnormalities is known when it concerns a clefting of lip and palate. So all you need to know is the cleft restricted to the lip or is it extending into the palate? If it is extending to the palate, how deep is it extending to? Is the uvula normal? If the uvula is divided, if the uvula is bifid, if you do not see the uvula too well, then there's a possibility that it's extending right the way up to the uvula. If the uvula is not seen, but the skin is present, there is an intactness of the skin anteriorly, you're probably dealing with an isolated clefting of the palate. Differentiation of the two is extremely crucial for prognosis. So make your sections the correct way, identify the defects, see the extent, and prognosticate accordingly. Thank you so very much.
Thanks, Dr. Mohit. It was a wonderful presentation covering everything what a person diagnosing cleft lip and palate should do. And experts are here to guide you and to incorporate all these things in your practice from to tomorrow. They are not so difficult if you keep on trying upon the normal patients. Coming to the counseling of this case, cleft lip, cleft palate. First, we need to remember our general consideration always. So every counseling goes through the same kind of considerations. And here, the prognostic indicators are risk of chromosomal and non-chromosomal anomalies, which is quite higher for cleft lip, cleft palate than for cleft lip, and higher for the bilateral cleft than for the unilateral ones. Worst prognosis is with a median cleft because of the associated holoprosencephaly and other severe midline defect. That is a frontonasal dysplasia. Cosmetic results depend upon the extent and depth of the defect. So first thing you need to see that whether there is associated cleft palate or not. So if the cleft palate is there, so the chances of chromosomal as well as the non-chromosomal anomalies is high. So you should be more aware of that, and you should do the counseling accordingly. Particularly in the cases of median cleft, it is the prognosis is much poorer. Cleft palate is associated with congenital heart disease. So we should advise for a detailed fetal echocardiography, and we should look for the congenital heart defects. The risk of chromosomal anomalies are also higher because they are associated with trisomy 13 and 18 and other few rarer chromosomal anomalies. The risk of non-chromosomal syndromes are also higher. They are very high, and because cleft palate may sometimes associated with only prenatally detectable sign of various syndromes, and parents must be made aware of this. They must be counseled that though we are just seeing the cleft palate right now, but they might be associated with few of the non-chromosomal syndromes because the chances are very high. And these syndrome, few of the common ones are the uh, Goldenhar syndrome, where the cleft palate is associated with the unilateral macroophthalmia and hemifacial macrosomia, and the Fraser syndrome, that is much more common, where it is associated with the laryngeal atresia, congenital heart disease, microophthalmia, external ear anomalies, and bilateral renal agenesis. So the parents must be make aware of this, even we are not finding other associated defects. Different other syndromes are also they are ectodactyly ectodermal dysplasia syndrome, frontonasal dysplasia, where we find cleft palate with anterior cephalocele and hypertelorism, Frin syndrome, where we have cleft palate, diaphragmatic hernia, and central nervous system anomalies. The again we need to see on the same point, that is whether they are isolated or whether they are syndromic. So if they are isolated, the survival is unaffected, and quality of life is good, but it also depends upon the severity of the defect, whether it is bilateral or unilateral, whether there is a cleft lip, just cleft lip, or they are cleft lipped and palate, and also the extent of the clefts and of the consequent cosmetic and functional surgical outcome. That is how good these functional surgical outcome will be. So we need to counsel upon these point. Again, we need to ask for a detailed anatomical scan by an expert to rule out the non-chromosomal syndromes, to see all these minor signs. We need to offer for karyotyping that is recommended in the bilateral cleft palate, but in isolated unilateral cleft lip or cleft palate, we should discuss these options, but that is not mandatory. Prenatal consultation with a reference surgeon is very important in isolated cleft lip and cleft palate in antenatally only, so that the parents should be aware of what they're going to face and how much functional ability or disability will be there after the birth, after the surgical correction. So we must ask these parents to visit for the reference surgeon in the antenatal period only. uh, now I'm inviting Dr. Niravan, ma'am, for the clinical inputs. Ma'am, please.
You see, everybody, am I audible?
Yes, ma'am.
Everybody today wants a picture perfect baby, a baby whom they can take for a photo shoot the next day. So when they have received this ultrasound report telling them about a cleft lip and palate, by the time they come to us, they are usually very distraught, very upset, very disappointed. And as a matter of fact, I have had couples who, even in isolated cleft lip and palate, in the absence of any other syndromes, any other aneuploidy, have requested me for a termination. Now, there comes the role of very empathetic counseling, because certainly they are going to start a very long road. And you have to hold their hand and tell them that it's not a life-threatening disease. And a multidisciplinary team is needed, which should involve not just a gynecologist and a fetal medicine expert, but also a neonatologist, because the moment the baby comes, especially with cleft palate, there are going to be enormous feeding problems. And a pediatric surgeon, as Dr. Krishna Gopal said, because you see, telling them at what age the surgery would be done They can show the before and after pics, make them aware of the cost implications and what are the expectations of surgery. This goes a long way. And in fact, when I was working in UK, there used to be support groups. I think that was a very important thing in counseling. And I don't know whether they are there in India or not, but since it's a society of fetal medicine, you all are getting cases from everywhere, probably. Putting such patients, such parents together, it gives them a lot of respite to talk to parents of children or meet them who have gone through this surgery and look at, what are the results, the functional impairment or the, implications, the final outcome which they have, because it can be really devastating to know that your child is going to have speech problems, hearing problems, or dentition problems, and a lot of psychological support. I think involving a psychologist in counseling may be important. So in this society, since it's fetal medicine, I think it's very important that it's not just a sonologist who writes the report and hands it over. It should be a fetal medicine person who can counsel them at that very stage before dispatching them with the report. So I think Dr. Gopal and all of you would agree. Primarily diagnosing and counseling there and then before they go to the net and receive half-hearted information and start crying. That goes a long way. I think that's what I have to say.
Thanks, ma'am, for the nice inputs and wonderful group. And we will certainly discuss in our central team about this idea of a support group for these kind of patients. Thank you, ma'am. Thank you so much. Our next case.